For decades, public health campaigns operated on a simple premise. Stopping substance abuse meant teaching people that drugs are dangerous and expecting them to make better choices. But when confronted with the actual ecology of human behavior, that premise fails to hold up. The strategy is rooted in what researchers call the moral corruption theory. It relies on the assumption that individuals who develop a substance use disorder inherently lack personal knowledge, hold a poor attitude, or simply lack willpower. This theoretical framework has actively stigmatized entire populations. It labels those struggling with addiction as weak or stupid, framing their situation as a failure to simply choose a different path. The fatal flaw in this logic is its starting point. It assumes that human choices are made in a sterile, isolated vacuum. Rigorous scientific evidence disproves this isolated choice model. Choices never occur in isolation. Individual-focused willpower campaigns fail because they ignore a foundational reality of psychology. Humans are products of the families, peer groups, schools, and legal systems they come from. This diagram illustrates the ecological model. We replace the isolated individual with a dynamic network, mapping their connections to surrounding systems. As they move between environments, these systems push and pull, actively increasing risk, providing protection, or creating competing expectations. Ecological risk factors include untreated psychological distress, family conflict, poverty, and specific cultural environments, where substance use is heavily integrated into social bonding rituals, like sporting events or family gatherings. Counteracting those risks are protective factors. These include having at least one dependable adult in a child's life, safe housing, accessible healthcare, and inclusive school programs. The starting point of modern prevention doesn't begin with a pre-packaged curriculum or simple intervention. It begins with a forensic, localized understanding of the specific environmental factors surrounding a population. To reduce statistical rates of harm, public health professionals must stop trying to fix individual willpower and start engineering the environmental conditions that surround those individuals. To map environmental interventions, public health uses a continuum of support. The horizontal axis tracks time and severity, from health promotion to treatment. The vertical axis categorizes populations from universal to selective to indicated. We start here. Universal health promotion. Universal targets focus on the entire community or school population. The strategies implemented here are designed to foster baseline well-being, strengthen conditions of support, and help everyone make informed decisions. A prime example of universal health promotion comes from a series of European school studies that bypassed standard drug education entirely. Rather than lecturing students on the dangers of narcotics, these schools engineered their environments to build protective relationships. They developed interactive classroom structures and created strong, unique identities using school mascots and logos. The direct result of this intervention was a significant decrease in student isolation. By providing a strong internal community, the schools eliminated the students' need to search for alternative, potentially high-risk groups outside the educational system. By engineering strong, inclusive identities at a universal population level, these schools achieved significant harm reduction, directly lowering their statistical rates of high school pregnancy and substance use. Moving one level up the matrix brings us to secondary, or selective prevention. Selective interventions target specific subgroups that possess elevated, identifiable risk factors. A common example is focusing resources on children who have parents with substance use issues. The precise timing goal of secondary prevention is to intervene while the individual is approaching the line of clinical disorder, but before a severe crisis or identifiable policy violation actually occurs. Consider the college binge drinker. They perform flawlessly in academic settings during the week, but engage in chaotic, extreme drinking on the weekend. Because the individual functions in their daily responsibilities, showing up to class and completing their work, they easily rationalize their high-risk weekend behavior as harmless. The primary hurdle of secondary prevention is successfully penetrating that rationalization. Public health workers must initiate change while the target is still highly functioning, before the behavior firmly crosses the threshold into pathology. At the peak of the prevention axis, we find indicated targets. These are specific individuals demonstrating early, identifiable high-risk behaviors or initial policy violations. Here we encounter a strict boundary between prevention and clinical treatment. High-risk behavior, when the individual still lacks functional impairment or physical withdrawal symptoms, is not a clinical substance use disorder. Clinical research reveals counterintuitive data regarding what happens when institutions ignore this distinction. When non-impaired, high-risk individuals are mislabeled and forced into clinical treatment facilities anyway, they often do not improve. Instead, the intervention actually causes them to develop the full disorder. It is a systemic requirement to keep preventative measures and clinical treatment strictly siloed at this specific boundary. Applying clinical pathology tools to environmental behavioral problems can actively manufacture the very disorder the system is trying to prevent. The final stage of the continuum deals with post-disorder stabilization. In prevention literature, this is known as tertiary prevention. In clinical settings, it is called ongoing recovery or aftercare. The line between treatment and prevention is murky here, but their focuses differ. Clinical treatment manages pathology through strategies like relapse prevention plans, while tertiary prevention focuses on building stabilizing community relationships and securing supportive employment. In clinical recovery frameworks, the treatment focus relies heavily on structured routines, such as attending meetings and actively managing mental health. However, there is a primary, often overlooked biological driver of relapse in this phase: unmanaged physical comorbidities. Conditions like peripheral neuropathy, tremors, or severe chronic pain are frequently unmasked only after a patient achieves sobriety. Tertiary prevention requires managing this physical pain to maintain behavioral stabilization. While this matrix provides a comprehensive architecture, there is a systemic failure within the current application of these strategies. The vast majority of these public health and prevention initiatives are focused exclusively on youth populations. Adults frequently grow up in supportive homes with strong protective factors, yet still develop a disorder later in life. Because adults are rarely targeted for prevention until they hit the criminal justice system or exhibit severe clinical pathology, public health misses a critical window for early environmental intervention. When we pull back and view the completed architecture, we see a complex, interconnected public health strategy. The ecological model accepts that zero-risk environments do not exist, and total prevention is impossible. The true, pragmatic goal of this entire matrix is harm reduction. It is about putting systems in place that systematically reduce the probability of a disorder occurring. To achieve this, modern public health requires replacing one specific question with another. We look at this typographic layout to see the shift. We must reject the old lens that asks why a person made a bad choice, seeking to blame their individual lack of willpower or knowledge. Instead, we must embrace a new lens that demands we evaluate the surrounding environmental ecology. Effective public health does not rely on fixing broken people. It relies on building structurally fortified environments.